They touched on a lot of themes that are really great for us today. Well, one I want to pick up on right now is creativity. There's a lot of creativity that goes on in this work that you're doing every day. And I want to introduce our first speaker, who is going to, I think, provide a little bit more inspiration for that creativity. Stacey Chang serves as the Executive Director for the Design Institute for Health, a collaboration between the Dell Medical School and the College of Fine Arts at the University of Texas at Austin. This is a first-of-its-kind institution dedicated to applying design approaches to solving systemic healthcare challenges, and they're working with invested stakeholders in the healthcare ecosystem to do that. Until 2014, Stacey served as the managing director of the healthcare practice at IDEO and the global design and innovation firm, and he holds a BS degree from MIT and an MS degree from Stanford University, both in engineering. Please welcome Stacey Chang.
Thank you. Thank you, Katie. Well, clearly I have the most unenviable role in today's activities, which is to follow Senator Watson. So I'll do my best to be half as entertaining as he is. So as Katie mentioned, my current role, which is only about 3 months old now, is as the executive director for something called the Design Institute for Health. And that combination is somewhat unconventional. So I'm going to spend a little bit of time sharing with you a little bit about that. But I want to reinforce something that Senator Watson said, which is a fundamental tenet of design thinking, which is that fear of failure is unnecessary when the kind of experiments you deploy are of limited investment and of limited risk. But when they're focused on learning, they're actually extremely valuable. And so we'll talk a little bit about that this morning. I'm here to talk about, more specifically, design thinking in healthcare, but in particular, its applicability to patient engagement. And I could stand up here and hand wave a lot of that, but it would be a little useless unless I gave you a little bit of background first. So let's start with that. You've either heard of IDEO and know a lot about the company or never heard of the company, and it's usually bipolar that way. And so I'm going to give you a little bit of background about the firm in particular because it'll help you set some context for what I'm going to share with you. So IDEO, if you knew the company about 20 years ago when I first joined, it was known as sort of the preeminent product design firm in the world. And so it was famous for having taken really iconic Silicon Valley technologies like the original mouse and commercialized that for Apple. We did the first laptop computer, anything with a screen that folded over a keyboard. We designed the Palm 5, which is the precursor to all the smartphones that allow us to tweet. And so we got pretty famous for taking technology that was the domain of really nerdy engineers and making it usable for average human beings. And along the way, we developed a process roundly known as design thinking, or sometimes as human-centered design. And that became our bailiwick. And we applied that to almost everything. And in the course of 20 years, we began to shift very significantly our work in this way. Our clients had originally asked us, how should I design this, whatever this happened to be for them. It could have been a barbecue grill, it could have been a left ventricular assist device, could have been the interior of a car. It almost didn't matter. But they had a view of what they wanted to design, and they asked us to design it. And then they began to ask us a different question, which was, what should I design? And the reason they did that was because we began to reveal things that they never knew about their consumers through this process called design thinking. They'd done all the market research they could have managed, and in every project they remarked to us, you teach us something about our end users that we don't know. Could we start asking you this different question, which is I want to move into an adjacent marketplace, I want to move into a competitive position against other in the industry. Help us figure out what people want, and then help us design it. So that spurred the growth of the company into a global one, 11 locations globally, 600 people, every one of us an unabashed designer of some sort, designers of graphic designers, industrial designers, engineers, software, business designers, MBAs, and a lot of PhDs in sociology and anthropology and psychology. And on the healthcare side of the business, we did a really broad array of things. Something you might expect, which was our legacy, medical devices. We also did really much softer things. For Nike, which is the second picture from the left there, we helped them develop a strategy to help keep populations active. One, because there's an altruistic nature to that, keeping people active keeps them healthier, but there's also a real business motivation for Nike, because people aren't moving. They have no one to sell stuff to. We wrote the original template for the health insurance exchanges for the states. We did that for California first, and all the other states followed suit. When healthcare.gov launched and that debacle, the federal government asked us to redesign it, and the current version is the one you see now. And then for the likes of Cleveland Clinic, that last picture is a glory shot of their new hospital in Abu Dhabi. We actually designed the patient experience for the delivery of Western medicine in a Bedouin culture in the Middle East. And we worked with most of the major academic medical centers in the US and many abroad as well, helping them develop anything from systems to services, processes, clinical spaces, and the like. So I share all that with you not to impress you, but just to give you some context around the work that was the output of what we did. Underlying all that was a process we call design thinking. And one of the most fundamental tenets of design thinking, better reflected in the title, human-centered design, is that we began with people. You know, lots of folks in Silicon Valley start with technology, and they believe that if they'll build it, people will come. A lot of our clients came to us trying to establish new business models. But fundamentally for us, we always began with people, because if you're not designing something that people want and that people can use, then your time and effort is wasted. And so this is probably the oldest napkin sketch around IDEO, drawn some 25 years ago by one of our executives. And what we're interested in is not necessarily what people say and do, although you can learn a lot from that, and a lot of traditional market research is focused on that side. What we're really interested in design thinking is what's behind the veneer, which is how people think and how people feel. Because behind that veneer lies the motivation for action, for engagement with health, for addressing disease, but fundamentally for the things that actually matter to people, and many times things that they are either unwilling to express or unable to express because they don't recognize it in themselves. They're not self-aware enough to realize. And so on staff at IDEO, and then also now at the Design Institute of Health, we have lots of folks who are really good at getting beneath the veneer. And the really unfortunate circumstance of that is if you spend enough time with them, they know all sorts of things about you that you don't want them to know. And so if you ever meet them, don't ask them anything about my psychoses. All right. So I'm going to talk a little bit about patient engagement and some of the things that we've learned over the years, really starting from the human motivation. So for us, just like in any other thing that we did, we started with what was beneath the surface and what actually mattered to human beings. And it turns out patient engagement in itself is not a single variable problem, as you would expect. It's an outcome, just like medical outcomes are the response to a lot of multivariate inputs. And there are a few needs that show up consistently. I'm going to share with you some of these, some examples of how people have addressed those needs, both in the consumer space and in the healthcare space, and then some questions that they raise for you as you're doing your good work. So patients want control, and that might seem obvious, but in healthcare in particular, we really grant them very little control. Usually the only control we grant them is the ability to say no, because we prescribe and foist upon them a protocol and a way forward which is informed by clinical research or good medicine. You'll see actually a very similar thing, and most of you will be familiar with this, which is airplane flight. So most of you have been on a plane, I assume, and the situation in that space is actually quite similar to being a patient. You're told when to sit, stand, buckle your seatbelt. They turn on the lights and off the lights for you. They control the temperature. They feed you when they want to. They hand you water when, irrespective of when you're thirsty. And so in a situation like that, you have very little control. And so the only thing you can fight over is the things that you do have control over, which is the armrest, right? We've all done that. The person in the center gets the armrest. That's the rule. But folks like Virgin have realized that if you grant a little bit of control back to the patient, it changes the dynamic entirely. And so what they've done, if you've ever flown a Virgin flight, either Atlantic or Virgin America, they have a very simple thing, which is on the seat back, you can order your drink, what you want, when you want it, and the flight attendant will bring it to you. And it turns out just that little bit of control changes the entire dynamic entirely. And there is a demonstrably, actually studied, less anxiety and cat fights that break out on Virgin than on any other airline. Turns out the providers prefer it too, right? Because they actually can be more effective in the way they deliver drinks to the patients. Clearly, I spent too much time in healthcare. To the consumers, and it's more efficient and it makes for better interactions. In healthcare, we actually designed an ambulatory surgical clinic for Chang Hospital, which is one of the major public hospitals in Singapore. And I could go on for an hour about all the different aspects that we had an opportunity to redesign. But in particular, one that talks a lot about patient control is really just this. And this is a button, a set of buttons on the inside of a patient exam room. And what it's addressing is the fact that every time a patient was in a room and changing into the hospital gown, they were in great fear that a physician would walk in or a healthcare provider would walk in while they were disrobed. And a very simple gesture, which was to give them control over the opening of that door, changed the dynamic between that patient and the anxiety level as they were preparing for what was probably something they didn't really want to engage with, which was a physical exam. That was notably the most important thing that patients told us about the redesign of their ambulatory surgical clinic. Truthfully, that door didn't those buttons didn't actually lock the door. Because that's a liability. If you lock the door and you can't get it open, what do you do as a provider, right? All it did was turn on a light on the outside of the door and let the provider know when they couldn't access the room and when the patient was ready for them. And that's a dirty little secret, but one that just as a gesture made a huge difference in the experience of the patient. A question that raises for us is how might you return some measure of control back to the patient? Not all of the control, because that can't happen in healthcare, but how do you give back just enough control that they feel like they have some domain, some agency in their experience? The second one I want to tell you about is about patience and exploration. Patients who are able to explore, and this is a corollary to control, turn out to be much more effective in the pursuit of their treatment. They tend to commit much better. This is a slide from a company and a client I can't tell you about, but suffice to say they sold drugs for hypertension. And one of the most interesting things was they saw the world in very black and white. You're either on our therapy or you're not, and that's no good if you're not. And what we convinced them was that a patient who had made the decision to be on therapy was actually much more likely to actually be adherent to that over a long period of time than one that had been told to be on therapy. So as part of the program we designed for them, which ended up being tremendously successful, was an online platform that helped physicians and patients make decisions about what they would explore before they committed to therapy. And the truth around hypertension is 90-some-odd% of folks will fail at the diet and exercise and lifestyle change necessary to reverse their hypertension. And so they'll all eventually end up on hypertension medication. But if you give them the choice to explore that on their own, even for a couple of weeks, and see what they can or cannot achieve, it turns out that the decision to take medication feels like their own, and the durability of that commitment is much, much higher, and their success is much higher. So giving patients an opportunity to explore, which is a corollary to control, but specifically an opportunity for them to make some decisions about the way they want to pursue their care, has a huge influence on the success of that care. So the question we often ask is, how might you allow patients to explore in beneficial ways, right? There are lots of ways for them to explore that are not so great, but if you can scope their exploration in ways that help them commit better, you'll all be better off. Number 3, patients want to participate in a way that can actually elevate the whole care team. So I'll explain that by way of an example. So we worked for almost a decade with an organization called Kaiser Permanente in California, which you guys are probably familiar with. We were helping them with addressing issues in nurse shift changes. Shift changes, as you know, are a source of a lot of errors, not necessarily because the individuals translating the information across shifts are incompetent. It's because there's a lot of information to be transferred, and because of human nuance, sometimes the critical things get forgotten. I won't tell you the whole story. I'll tell you some more of the backstory in a later example. But ultimately what evolved out of that, one of the solutions that the nurses themselves designed was this board, which is called Your Journey Home. And it sits in the recovery rooms in labor and delivery. So after you've given birth and you're recovering and you're waiting to go home the day or two that you're there, it's really simple, very low technology. It's merely a board, and hung on the hooks are all of the activities that have to happen before you can go home with your child. Everything from filling out the birth certificate to doing the immunizations to getting a circumcision to whatever it happens to be. And as those activities are finished, they're turned over. And so there's a visual, physical tracking aid that helps the two nurses keep track of what's been done and what needs to be done. And the conversation then happens, that transfer happens in the patient room, and that serves as a reminder, a mnemonic to help them remember what's going on. But the real secret is this. While that served as a nice aid, mnemonic aid for them to remember what had to be told, the most important thing was that the patient, that conversation was happening in front of the patient in the room. And it turns out the person who has the most deeply vested interest in a successful outcome turns out to be the patient. And they would fill in the gaps when the nurses would forget something. They would say, oh, no, actually, we filled out the birth certificate. We're about to fill out the birth certificate. That person's coming in the next half hour. And that would fill in the gaps for the nurses. So the patient actually had a role that was really effective in helping the nurses transfer the care protocol. And so the question for us is, how might we elevate patients to an appropriate role in the care team? And very carefully chosen is that word appropriate. There is a role for them. And as healthcare moves more and more out of the four walls of the clinical institution, they're going to have an increasing role. We live now, decades with chronic diseases, and we're going to do that. We're going to live not in spite of the disease, we're going to live with that disease. And most of the context of care will be the home and the community. So how do you give the patient some control over that? How do you give them a role in that which is appropriate and that they can facilitate? So the last one is this notion of patients needing a positive feedback loop. And the shorter or more unexpected, the better. Let me explain. We're going to go back to frequent flyer. I spent as a consultant many, many millions of miles in the air. And one of the things that I often said to my poor and suffering wife was, my status as in any frequent flyer mile was an indirect proportion, inversely proportional to my quality as a father, because I wasn't at home ever. But here's the interesting thing. I couldn't stop tracking my status, right? And some of you who fly a lot will recognize that as well. And so there's actually two really interesting things that the airline industry has discovered in keeping us hooked to their service. One is they're rewarding you for things you're already doing, right? You have to fly anyway. And they're like, great job. Thanks for flying with us. We're going to reward you for that behavior, right? And you're on an airplane anyway. And you're like, hey, look, I am pretty good. I fly a lot. Good for me. The other thing is the elusive upgrade, for which there is no rhyme or reason, mostly. There is, but they won't tell you. And it's a little bit like playing golf. You're terrible at it, at least I am, and every once in a while you connect on a ball, and you're like, I can do this. I can do this a lot. And the upgrade is exactly the same thing. They don't give you any rhyme or reason, and every once in a while, just when you're about to throw up your hands and say, I'm never flying this airline again, they're like, congratulations, you're in first class. And you don't know, and it keeps you hooked for a long time. So creating a feedback loop that reinforces your behavior is actually pretty critically important. In healthcare, I'm going to give you a slightly softer example. You see that in a very successful program called Weight Watchers. Weight Watchers, by and large, has been proven clinically to be one of the most effective approaches to actually losing weight, one of the most durable ones. And one of the things they do is they simplify the engagement down to points. So my mom's a clinical nutritionist. She looks at a meal, instead of saying, oh, that's short on vegetables, she'll say, oh, you're short on niacin, and she'll go make something to fill that gap. For your average layperson, that level of nutrition knowledge is actually not just impossible to understand, but also daunting and a bit of a discouragement. Weight Watchers made it really easy by turning it into points. And even better, you could earn points. You could earn good behavior. So if you go for a run or you do some exercise, they'll give you extra points, which you can spend on food, indulgences. It turns out that feedback loop is really effective, but they also learn how to game it, because the points you earn don't nearly cover off the amount of exercise, the calories that you burned, right? So your reward is actually smaller than the work that you did, but you don't know that as a consumer. And so they're actually gaming the system in the feedback loop to even gain some advantage as well. So a question that raises for us typically is, how might you provide patients with a feedback loop that's actually self-perpetuating, that they are keen to actually continue to do because it reinforces behaviors and needs that they already have. So I'm going to take a little bit of a left turn in the last couple minutes here, and about 10 minutes left here, so we'll save some time for questions as well. No patient engagement strategy is monolithic. We've worked with a lot of institutions over the years, and there is absolutely nuanced to your population, the geographic locale and where you are, certainly to the cultures in which you operate. And so it's important that any process you design for patient engagement, and I know Mark's going to talk a lot more about this, is to appreciate the nuance that has to be developed in any specific endeavor. And for most organizations, this is about moving, in healthcare especially, from an operational mindset into a learning mindset. You know, healthcare systems generally are built to optimize their operations. They learn how to be more and more efficient. Lean Six Sigma black belts are all over the system, and that's actually really, really important in a system that's as complex as healthcare. But as Senator Watson talked about, you actually have to learn. You have to fail in ways that don't risk lives, but you have to learn. You have to fail in order to learn. And as organizations, you have to set up the context for that learning to happen. And so what we've learned over the years in helping design the organizations that then themselves are innovative are a couple things. And they are three conditions. One is direction, the other is permission, the third is support. You can't actually get an organization to change and learn if you don't actually put all three of those things together. And I'll explain that by way of example, but let me define them first. Direction is pointing the organization in the direction that you want them to go. Permission is actually allowing them to take the time and energy to go pursue that. Support is actually giving them the resources to do the work that they probably haven't done before. So when we did the work with Kaiser in particular, all three of those things became manifest. One was direction, which is we want to improve transitions in care internally. It's really clear, and they created metrics that they wanted to measure that by. The permission was actually allowing the nurses themselves to do the work, to actually explore, to develop experiments. And the support was actually tools and resources and consultants like us to actually help them pursue that in a directed and cogent process. And they came out with a lot of things. If you actually read the case studies, and they've made HBR and all those sort of things as well, you'll learn a lot about what they ultimately resulted in. But actually what was most remarkable was that it functionally created a different kind of an organization where the nurses themselves felt empowered to do the work and actually were very capable. And they became the spread mechanism within the organization itself. They were the ones who championed the process, the ones that created cohorts of other nurses in other locations that then could replicate their success, and they created a groundswell movement that way. So I'm going to end by just saying, you know, change is hard, especially in healthcare, but it isn't impossible, and it's really a matter of design, right? You know, a lot of things in healthcare have been ill-designed or unintentionally designed. We have an opportunity here to actually do that with intention and with an end in mind. So I'll pause there. Thank you. We have a few minutes for questions. Yeah, 5 minutes. And I think there's some roving mics. So if you have a question, raise your hand, and someone with a mic will accost you. Yeah.
Can you hear me?
Yeah, I can.
Okay, I'm Julie.
Hi.
I have a question. You made a very succinct statement right before you talked about airline points. You talked about positive feedback loop and that it must be a surprise or spontaneous or something like that. Could you restate that sentence?
Yeah, so really the gist of that is that a positive feedback loop is really important. You know, I'll give you two examples. One is hypertension is a really tough disease to manage because if you're adherent to your medication, the best thing is nothing happens. You don't feel any different. You don't get a heart attack. You don't die. All you do is feel lighter in the wallet. If you have GERD, if you have heartburn, adherence is really easy because if you don't take your medication, it hurts, right? So you have to create a positive feedback loop, and in cases where there isn't one, you have to create a surrogate one, whatever it happens to be. It turns out that can even when that positive feedback loop is in place, which encourages your behavior, you actually still need a prompt every once in a while, a surprise that helps you realize that the work that you're doing is good. And so creating momentary, unexpected and momentary input that is unexpected is actually really useful in sort of renewing that commitment to your therapy.
Thank you.
Yeah. Other questions? One up here in front.
Design better healthcare.
Great. I'll repeat the question. So the question was, what is the Design Institute of Health up to? Like, why are we here? We are a UT entity, and as Katie mentioned, a joint collaboration between the medical school, which is obvious, and the College of Fine Arts, which might be less obvious, but that's where design is housed at UT. We are actually a resource to the broader community. Although we're being paid for by UT, we're working very closely with the CCC, Central Health, Seton, obviously UT, and all of the departments of UT to actually help elevate the health of the community. And we're doing that in a lot of different ways. So we will, frankly, design anything. And so we're designing one of the first clinical spaces that's going to be built at the new medical campus right now. We just finished a project understanding what health means to a community, in particular Austin, and we'll be sharing that more broadly. Because if you ask healthcare providers what health means to them, they'll tell you sort of the traditional definition of healthcare. If you ask community, they'll tell you a very different thing. And we're trying to reorient a lot of the systems here to understand that a community's definition has a lot more nuanced definition than a healthcare provider's. We'll design services and processes, but ultimately we're a resource, an enabling resource to this broader regional community. Whatever needs to be designed that hasn't been designed before, we're happy to engage and consider because it's all in pursuit of the greater good. Any questions?
Final questions?
One more here. No?
Stephen Pont, I mainly work with health and wellness, childhood obesity, and I'll hit you up for some other ideas and thoughts later. But it caught me when you mentioned the hypertension and maybe a little bit fatalistic saying that most folks can't maintain enough healthy changes to reduce their weight and maybe not need that hypertensive med. Do you think we're done there, or do you think there's opportunities to maybe further help folks make those healthier choices and really reap the benefits of the healing power of nutrition and more physical activity?
I'm as the son of a clinical nutritionist, I believe there is always hope. One of our fundamental challenges, and you guys would all recognize this, is that we actually have to raise the health literacy of the community, right? You can't inform somebody about what they're doing if they don't understand it. And so that's one of our challenges. But if you look at chronic diseases, you look at the DPP, the Diabetes Prevention Program, right? That is actually in many ways a more complex disease to address, and the studies have shown that that's actually really effective. It's a really difficult program to facilitate. There's actually a couple companies, one that IDEO launched a few years ago called Omada Health, that does that on an online platform, is very, very successful. So I actually believe there's hope, both enabled by technology and also by a rise in literacy, and that's a responsibility, I think, of all of us.
Thank you very much, Stacey.
Thank you.
Oh, one more question?
One more.
Okay.
Go ahead and ask it. I'll repeat it. I can.
You made some very good points about what nurses can do and healthcare providers. Is any of the points that you have spoken about, is it incorporated in the education of the nurses?
Yeah, that's a great question. Yeah, so the UT nursing school has been around for a very long time already. And the medical school in particular is focused on training physicians. That being said, we're going to be on a campus with the nursing school, and very much of the educational curriculum we're developing for the medical school. And I'm associated with the medical school. I don't represent them, so that's important. But one of the things we're helping to design is a third-year curriculum for undergraduate medical students. It's interdisciplinary, which means that we recognize that the future of healthcare is delivered as teams, and actually nurses are probably the most important part of that team because they have the most interactions just on a time basis with patients. And so changes in education are necessary, and we'll be working through UT to evince those changes. Thank you.
Thank you very much, Stacey.
Thank you.